There's somebody driving.
I think he's coming the Rahul Gandhi of Turkey.
75 100 8
I think the weather must be making everybody sleep. What brought on this change, Sanjay? 4:15 yoga.
Oh, like lockdown effect. Nothing to do. Sleep early, and then you get up at 4:50. But like yoga at 5:30, tennis from 6 to 8, and now I'm going back.
Wow. Tennis
Wow.
also, yoga also, meditation. Oh God, you're going to prove me wrong today.
there is something, Mahesh's sleep today.
You will prove me wrong today. Oh God.
We have to find out the player with the tennis.
Yes. True.
Yeah. Which balls you are hitting, huh?
Yeah.
That will come to know now.
That we didn't say that.
I know. How bad is the corona in Bangalore?
I mean, for the population we have, it is anticipated, yes. Not that way, it's not that bad.
Okay.
But the government is stupid. They're asking nursing homes where they don't have CPAP or ventilation to give the beds for ventilation. They're putting everybody into BMC where there is no specialist who can look after. So if you look at Times of India today, 90 patients were put on ventilation, 89 have died.
Oh.
I think the data from New York was also not reassuring, 87% mortality.
But New York, at least people had experience with ventilation, and the people were geriatric. Here, obstetricians and orthopedicians are rostered into ventilation duty. So that's...
Delhi Fortis is also doing the same. All doctors have been put on COVID duty almost every alternate day.
Really?
Delhi Fortis, yeah. A pediatrician friend of mine there, he's the director of pediatrics, is doing COVID duties. And even at Chandigarh, Fortis is full of COVID patients. Because there are no elective procedures. No elective cardiac procedures.
But pediatricians at least are better because they will have at least some amount of knowledge about ventilation. No?
Yes.
If not, at least a compassion.
True.
I had an obstetrician friend in PGI. So when I was in medical college, PGI at that time. So he was telling, so that time the anesthetist used to come for resuscitation. So he will page, there is a cardiac arrest in obstetric unit. Please come fast. And since he would not come, he says, please page anesthesia, sir. There is a severe cardiac arrest. So,
Severe.
So we'll start.
Yeah,
we can start.
22 people have joined.
Okay.
We'll start now. Okay, good morning, everyone. Welcome to 133rd our weekly clinicians virtual meet. Today we have a wonderful speaker by name Dr. Irananda. Actually needs no introduction. And for the benefit of the people who don't know, he is a very famous neonatal and pediatric consultant. He has vast experience, more than 25 years of experience in pediatrics. He has completed MD from PGI Chandigarh. He has publication in national and international journals. And he is a very entertaining speaker. at the end of this talk, he will make sure his message is passed across. So, Dr. Mahesh Randan, over to you. Please take over.
Thank
And
you.
I
Thank you.
request everyone to mute your mobile phone.
Thank you so much, Dr. Prasanna, for the kind words, and good morning. Dear friends. I understand ever since the lockdown, we get to hear about two things only. Kitne case and mera webinar hai, please attend karna. Or my friends in Bangalore, nalle belige sariyagi entu ghantege nanna upanyasake khandita banarapa. So even my CSF was overflowing with these, and then came in a message from Dr. Prasanna. Next week, your turn webinar. I tried seeking mercy, but he said, Corona or no Corona. We are the crown kings of webinar, longest running, 133rd webinar, nice number, just do it. So I said, okay, just do it, the Nike style. So I decided that, no more curses from people who are forced to attend these webinars. So friends, trust me, in this Cloud9 family production, with all my creative juices flowing, I assure you, hello?
Yeah.
Juice
Go ahead.
stop flowing also. Juice didn't flow.
No, the slides are not moving forward. I'm so sorry.
Mahesh, stop sharing and restart sharing, then it will work sometimes.
Okay, I'll do that. Yes, thank you so much. So with all my creative juices flowing, I assure a smile on your face by the end of this session. And once again, it's a pleasure to be on this platform, sharing and learning new things about pediatrics and life in general. Rationale antibiotic therapy, the topic in itself should trigger in a lot of introspection. And while preparing for this topic over the last few days, I did introspect along with a few close friends and came to this conclusion that yes, we all are inking antibiotics more often than we should. We are also aware that both decision to prescribe and not to prescribe antibiotics is associated with risk and its benefits. So the take-home message from today's talk would be when not to use antibiotics. My sincere gratitude to both renowned senior pediatricians of countries whose style of practicing pediatrics I am deeply influenced by. Their contribution in screenplay, Dr. Pramod Jog, and dialogues, Dr. Y.R. Ramdekar, has been immensely valuable. Also can't forget contribution of Dr. Nandini, who in spite of being a pediatrician, helped me deliver my Kannada dialogues. And Dr. Prasanna and Dr. Nilesh for a busy media campaign that has ensured or will ensure good participation. Now, coming to my talk, penicillin was the first antibiotic discovered in the year 1928 by Alexander Fleming, and I'm sure he didn't realize that he has simply revolutionized medicine by saving millions of people over the next few decades, especially in the Second World War. Now, this is, and I'm also sure of the fact that he wouldn't have been happy at this growing antibiotic resistance, which has rendered hundreds of new antibiotics useless, and that too just within a few years of their discovery. And as I mentioned earlier, that the biggest driving factor for the antimicrobial resistance was the use of these drugs, rather misuse of these drugs. And just quickly have a look that, how soon the antibiotics like penicillin, tetra, erythromycin, and vancomycin became useless after the introduction in the now, this is about the resistant isolates. See how much they have grown over a period of a few decades, and at the same time, this is also the receding number of antibiotics that are coming to the market. So the situation is certainly very grim. This is the figures from the resistant isolates of India 2007 to 11 across the hospitals, and You can have a look at the percentages. Most of the isolates are resistant to the tune of 10 to 96%. And this is an alarming situation. We do not realize this unless we have a relative who's admitted in ICU and is attacked by resistant bugs. So this actually spells doom for us. Now, let's see, why are we in a mess like this? Here, look at the journey of medical sciences, which is from 2000 BC to 2000 AD, which started from roots to prayers, to potion, to penicillin, to pafloxacillin, back to roots. So where do we go from here? It's ashes to ashes, dust to dust, all our handiwork. Now, till recently, most diseases were managed by doctors across the world on the basis of their intuition, their gut feeling, and of course, a little bit of experience too. So back home in medical college, my professor of pediatrics would say, "Do you hear this shriek? This is tubercular meningitis. Start ATT." And the poor resident would say, "Wow, yaar, kya baat hai?" Then he would ask, "Sir, CSF, kar lena, pehle jaan bachao." And then we had similar such experiences in most departments that formed the foundation of all the management. But then our science is no longer the same. This is an era of evidence. So entered my senior resident at PGI, Parduman Singh. And he would say, "Daya, sabut, sabut la, reference la, fake mat, RCT la, Cochrane review la." Cochrane, this was the first time we heard it, was a scandalous word. So thanks to him and like him, the irrational practices which were continuing across India actually started getting questioned. In a country where the strikes are everyday affair, here comes another crazy reason to strike, but this time it is the human race which is at the receiving end. Let's see, how does antibiotic resistance occur? So during an infection, our body is attacked by sensitive bacteria, as well as there are a few resistant bugs. You give antibiotics, the sensitive bacteria and a few common cells get destroyed. Resistant bacteria will continue to multiply, so that we have a predominant sensitive population getting converted into a resistant population, a phenomenon which is called as natural selection. And at the same time, there occurs transfers of this antibiotic inactivation machinery from the resistant bugs to the sensitive bug, which in turn again become resistant, a phenomenon which is called as cross resistance. So moving ahead, this news in a UK-based newspaper paints us, the subcontinent, in bad color, as if दुनिया का सारा गंद हम ही produce करते हैं. So since 2010, they have been crying hoarse that India is the largest producer of resistant bugs in all direction, which actually is a cause of concern. And now latest is this NDM, New Delhi metallolactamase. It's quite a funky sounding enzyme, which can render most of the new antibiotics useless. And they've also identified the source of this bug in the mushrooming and plastic cosmetic surgery clinics of Gurgaon. And a word of caution for the youngest looking guy at our Gurgaon center. He asked, "Is the situation so alarming?" So I said, "Wazir Alam, haan, kafi bure haal hai." Now, introspection time. We at Chandigarh are doing prescription audit amongst close friends. So this is one of the cases which was taken up for prescription audit. This is a 7-year-old girl, resident of Chandigarh, came with history of fever, high grade, had sore throat for 2 days. On examination, had, she was febrile, had a toxic look, had tender jugulo-digastric lymph nodes, and the chest was found to be clear. And the look of the tonsil, obviously the prescription doesn't come with the picture. So I presume either it was this or this. And finally, I settled for this particular picture, because the diagnosis made by the said person was URTI, and what he offered was paracetamol IBU combination for pain relief and fever, and a combination of oral third generation cephalosporin with beta lactamase, 1 teaspoon twice a day for 3 days. This child reported again to the same doctor on day 2, continued to have fever and sore throat, azithromycin was added. This child developed diarrhea and reported to a rapper. I said rapper, not raper. So I know that all of you are muted and you have your daggers drawn. You just wish to attack this person who has prescribed this. And I'm sure most of you would feel that, the way the diagnosis has been made, the prescription, the choice of antibiotics, and haste, each and every point, there is irrationality. This is what we are going to look into our talk in the next few minutes from now. Now, let's see who all are prescribing these antibiotics. 74% of antibiotic get prescribed in general practice, which would mean that there are, doctors from allopathic medicine, and then doctors from, alternative systems. And then we have Bengali doctors, and then we have quacks, and then we have chemists. Only 11% of antibiotic get prescribed in hospital inpatient, and then these are the minuscule use. Now, confirmation of this finding was confirmed in this MALAD study, which is a community-based prospective cohort surveillance study across 9 countries of 5 continents, and subjects enrolled were healthy children, more than 1.5 kg, no chronic condition. These were examined twice a week for use of antibiotics by 4,400 healthcare workers, and they were basically examined for use of antibiotics in non-bloody and bloody diarrhea, as well as upper and lower respiratory tract infection. And the results were that on an average, about 5 courses of antibiotics were used per child per year for immune duration of 3 to 7 days. Pakistan and Bangladesh reported almost 11 courses, whereas Brazil and South Africa reported 1 course of antibiotic per year. So the third world continues to overuse antibiotic when not required in non-bloody diarrhea and URTI, and sometimes also underuses these antibiotics when it's perfectly justified for a bloody diarrhea and LRTI. Now, this is the Indian scenario. This study, which is published in 2019, is the first ever and largest estimate of antibiotic prescription by antibiotic classes, age groups, and ICD-10 mapped medical condition carried out in Indian cities with a population of more than 1 lakh. Main findings were 519 prescription handed out in private sector in the year 2013, translating into OPD basis antibiotic prescription rate of 412 per 1,000 person per year, far better than Germany 561, UK 555. And this rate has been rising and has risen up by 25 to 100% in a few recent reports. So it is proving that there is misuse on upsurge at all level. And I wonder that why is the misuse there in this age group with robust health? Now, majority of antibiotic, now this study further concluded that majority of these antibiotics were used for diagnosis of URTI, which would mean acute nasopharyngitis, acute pharyngitis, various kind of coughs. Generally, these infections are viral in origin. They are self-limiting. Hence, in light of evidence-based treatment guidelines, a significant number of these antibiotic prescription might be irrational. Also, worrisome was the fact that, a lot of doctors, especially from India, were resorting to using high-end combo antibiotics, what I call tam-tam antibiotics. And the potential reason for misuse was stated to be not only high burden of disease in our country, but also lack of adequate training, poor lab services, and expectations from the patient. And the most crucial was the pressure of industry on gullible doctors at all levels. So once again, introspection time. A data on use of antibiotics in URTIs at Cloud9 Jayanagar, very acceptable, 22%. The commonest molecule used was coamoxicillin in 85%. May not be in sync with most guidelines, but then where the hell is amoxicillin being manufactured? You hardly get plain amoxicillin in market. So far more rational than other hospitals in Bangalore, which were reporting a usage of almost 74%. I am sure that each Cloud9 center has to look into their antibiotic usage on rationality meter. Now, why rational antibiotic therapy? Because that's the only way if human race has to survive. Also for better care of patient, and at the same time, if we prevent misuse, we will also reduce the antimicrobial resistance. And of course, lastly, to reduce the cost of treatment. And then the factors and the question is that why are we misusing antibiotics? So researchers have come to this conclusion, the same conclusion of this largest prescription audit, that it is usually because of lack of awareness. There is a fear of secondary infection. There is a fear of losing patient. And some of the doctors would say that it gives them a false sense of security. It gives them a security that nothing can go wrong. Of course, it is a false sense of security. And some of them prescribe antibiotics because of pressure of anxious parents. Once again, a wrong practice. Now, as we celebrate World Rationale Antibiotic Day on 28th of September each year, this rationality is here in a mnemonic called Rationale to fit in some aspect of rationale antibiotic prescribing practices. I will be taking each one of these letters and quoting you examples. Now coming to R, This is the first letter. It is in medical sciences, there has to be a reason behind every action that we do. So it is a PR examination, a direct laryngoscopy, or ordering a urine or a blood test. And so is true for inking antibiotic. But before that, our thought process should be, is it infection? Is the fever because of infection? If so, is it bacterial? Is it viral? And if it is bacterial, then what is the likely organism? And then we should think about the right antibiotic in right dose, right route, right frequency, right duration. R is also for keeping in mind the reaction, the adverse one to various antibiotics. And lastly, R also refers to referring to a handbook for pediatric dosing to be appropriate in your prescription writing practices. Coming to A is academically updated decisions. So we have IAP, AAP, NICE, and CDC, which come up with these updated guidelines every few years. And the basic principles of these guidelines are, as mentioned, the routine use of beta-lactam and beta-lactamase inhibitor combination should be avoided, as they are expensive, they have more adverse effect, and at the same time, they do not offer any additional advantage. We know ceftriaxone is the drug of choice for treatment of enteric fever, but there is no benefit of adding ceftriaxone with tazobactam, what I call tam-tam antibiotics upfront, as salmonella has rarely been shown to produce resistance through beta-lactamase. We also know as neonatologists that widespread use of third generation cephalosporin has rendered their use ineffective by the gram-negative bacteria because of the production of extended spectrum beta-lactamase by these organisms. And the same is true for extensive, crazy misuse of these third generation and second generation cephalosporin, which were used for, any indication, any age group. We know that combo meals look good, but combo antibiotics, as we get Powergel and Vesagil, they are no good. Thankfully, irrational combination like these have been condemned, but yet not eradicated. Lastly, in a desperate situation, when we have a child who's less than 3 months in a desperately sick child or a child who's in ICU, we should always prefer bactericidal drug over bacteriostatic, ignoring the sensitivity pattern to bacteriostatic drugs. Now, T in the rationale is for training of minds, about 3 O's, which is organ involved, the organism, and the option we have available for the offending organism. But in reality, none of us follow this standard operating protocol for choosing a proper antibiotic. We should train all the members of the unit together so that to have a uniform antibiotic policy. At the same time, we must tame the parents who have a lot of queries, and they pressurize us to give antibiotics. Remember, you are the pilot who's going to fly this aircraft. And last is the tracking of the pharmacist, very, very crucial, because he's disseminating a lot of gyan about your prescription to your patients. बहुत heavy dose लिखा है, side effect होगा, पूछ के देख लो डॉक्टर को एक बार. Must tame these, must control these pharmacists. Coming to I for instruction. So it is expected that a good clinician will give time and speak up about the irrationality of antibiotics in viral infection. And when prescribed for a confirmed bacterial infection, will explain the dosage frequency, about the possible adverse reaction, and why is it important to complete the course. One must also be able to identify Googling parents, put to rest their rationale or irrational queries. So in nutshell, more is the written instruction, less will be the space available for writing the medicine, and one must also keep learning from the prescription practices of fellow colleagues like this prescription, and keep improvising one's own. Look at the name of the doctor. Coming to, in a non-localizing infection, O is for organism search. So before starting any antibiotic therapy, one must develop a culture of sending culture. And while doing so, one must avoid contaminating the culture bottle. And this one is for the pediatric resident. Please, please, please listen to the plea of culture bottle, which says, Rang de tu mohe gerua, meaning thereby inoculate adequate amount of blood. Poor yields of positive culture is certainly on account of this. And when the report comes, one should be able to differentiate between a commensal and a pathogen, and also should remember that in vitro sensitivity to a particular antibiotic does not always result in cure. For example, Aminoglycosides alone cannot cure enteric fever or a staph infection, even though the antibiogram shows something else. Lastly, sometimes an injectable antibiotic is marked for oral use by simply adding a suffix O. So we have Taxim O, Monosef O. The spectrum of these O's is not the same as the IV preparation. So we have to be careful about using these. Now, N in the rationale is for noting down a working diagnosis. So even if you're not sure about the diagnosis, you must at least put a provisional one. And then there are lots of no's mentioned. That would mean if there is no fever, there is no infection, there is no antibiotic required. And the bone of contention is it viral? Is it bacterial? So quick recap for the younger doctors who are here. Viral infections, often the fever will be very high at onset. There will be involvement of multiple organs. So the child will have a congested nose, congested throat, congested eyes. There will be multiple people involved in the same family. And in between the fever, the child is almost always normal, usually subsides by day 3, day 5. Whereas bacterial infection, there may be variable fever at the onset. There is worsening severity, so that by day 3, day 4, the infection tends to localize, so that we have specific signs of tonsillitis or otitis media. And the child is often looking toxic and sick looking in spite of in between the fever as well. So friends, if you pen a provisional diagnosis of acute nasopharyngitis, probably viral, acute watery diarrhea, probably viral, acute bronchiolitis, probably viral, then your hands must tremble, your conscience must shake while writing an antibiotic. So to avoid such a hesitant pen situation, isn't it better to pen down your provisional diagnosis so that at least you will be questioned, your conscience will question you, and then think before you ink the antibiotic. And medico legally also, it is far safer to be proven to have given a wrong diagnosis than wrong treatment. अरे यार उसका तो treatment ही गलत निकला. It is so insulting when patients talk like this. Now, antibiotic policy. Even if you're managing a solo practice, you can still have an antibiotic policy which is tailor-made to your kind of practice. And in fact, one must always be open to prescription audits, as we do here in Chandigarh, in a closed working group where healthy analysis and discussions can pave way for rationale antibiotic prescription. A also stands for avoiding double standards, that is, writing a different set of antibiotic in clinic, different in a hospital, and speaking totally different in a conference. L is also for local sensitivity pattern. One must keep a close watch on all the cultures that you send by tabulating their reports. One can also have access to the data from various private clinics and hospital, guide therapy. L also stands for learning to improve minimum intelligence concentration. Now, three major circumstances under which we are prompted to use antibiotics. First is where we anticipate an infection. We use antibiotic even before infection has developed, something which is called as prophylactic antibiotic. Second, it is common instance amongst the neonatologists where we suspect infection in a symptomatic neonate but have no lab results. We give antibiotics, which is an empirical antibiotic therapy. And third is when we have a bacteriologically confirmed infection, we use a definitive therapy, which is straightforward. Now, coming to prophylactic antibiotic. Prophylactic antibiotic are classically used at all our centers for surgical prophylaxis. We give single dose 1 hour before, just before the incision, and it is usually for care of contaminated and clean contaminated surgery. It is standard of care, has brought down misery, has reduced the expenses, but the prophylactic use of antibiotic in animal far exceeds its use in human beings, and it is the major reason for antimicrobial resistance through horizontal transmission. Now, coming to most important, most crucial, the empirical antibiotic therapy. Now, on many occasions, it is difficult to identify the organism. Hence, the selection of an antibiotic is an educated guess, which depends upon the system involved and the prevalent organism. For example, acute tonsillitis, otitis media, bacillary dysentery. On the other hand, we have a patient who has fever and has no localizing sign. Here is the true challenge. Whether to start or not to start antibiotic would depend upon the urgency of situation. Sometimes a close daily follow-up or even 12-hourly follow-up may be necessary before committing a patient to antibiotic. And E here also stands for economic condition of a patient. Ever gone to a chemist? Try buying a 5-gram tube of mupirocin or 10 tablets of any third-generation cephalosporin. It's steep. And E is also for ethical consideration. We know that we are busy. But that still doesn't justify our ignorance about the recent advances, and which we seem to learn from our academic gurus. You know who I'm talking about. So please don't start using antibiotics or a new drug for the sake of novelty, maybe some pressure. It will do humanity some good. Now, coming to empirical antibiotic when. In OPD practice, for a clinically confirmed infection like tonsillitis or otitis media, a short course of empirical antibiotic therapy is perfectly justified. Next, where there is a strong possibility of bacterial infection, as in a suspected UTI, we send a urine routine and urine culture, start antibiotic therapy with cefixime or nitrofurantoin pending the lab results. Also, in a non-localizing fever, in a child less than 3 months old, immunocompromised patient or ICU setting, empirical parenteral antibiotic therapy is perfectly justified after sending in labs. Now, continuation, if we have a clinically confirmed or a radiologically proven pneumonia or a pyoderma, again empirical antibiotic therapy is accepted. A word of caution about when we come across a recurrent infection. Can we treat each episode with a course of antibiotics? So viral infections are known to recur, but not bacterial infections in a normal host. But in case we come across recurrent bacterial infection of the same organ system like recurrent pneumonias or recurrent UTIs, one must always look for structural, functional, or an immunological cause before committing this patient to antibiotic therapy. Coming to what empirical antibiotic? In a community acquired infection where prima facie there is no drug resistance expected except an enteric fever, a single oral drug is perfectly fine. On the other hand, if we have a complicated serious infection like a pneumonia or an enteric fever in a normal host, we will consider parenteral antibiotic, single or dual, based on epidemiology. Once we have committed a child to antibiotic therapy, we must back our decision to continue antibiotic for at least 48 to 72 hours before seeking clinical improvement, which is exhibited so well in an unadulterated child, a child who has not been given irrational antibiotics. One can continue the same course for a recommended 5 to 7 days. On the other hand, if the child is not better, it is time to reevaluate, re-examine, and review your diagnosis. Any empirical change, any empirical addition the second time without investigating will be purely irrational. This is an algorithm for a child with suspected infection, which I'm going to skip. And I'm sure you must have come across a number of them in textbooks and journals. You can modify it as per your needs, keeping rationality of your prescription in mind. Now, if rationality is the need of hour that we recognize, then we can't get away with irrationality. So friends, we must all be rational as a group, not in isolation. I think we pediatricians see a lot of infectious disease. We have a great responsibility to use antibiotics appropriately, not only for an individual, but also for the entire community. Busy clinicians are likely to become members of one of the two society. In no guilt society, there is no remorse, there is no punishment for misuse, or no shame society where there is no shame in using any drug in any combination in any situation. Though it is a challenge, we must dissociate ourselves from any such society, instead form a group on sound scientific principle and right moral standards, a rational antibiotic prescriber society, and wrap our way to good ethical work. Now, interesting story. I hope you know about this Deepika Kumari. She is an ace archer who, on coming back empty-handed from Olympics, noticed these perfect bullseye shots in a school playground. Perplexed and jealous, she said, "Who did that? How could one do that?" So she could only be consoled by her coach. He said, "Oh, one of your young fans who has this habit of shooting the arrows first and then drawing circles around the arrows. What a relief it must have been for this damsel in distress." So, for all the Limbarams and Deepika Kumaris here in the audience, in practice, we should not hit antibiotics first and then keep rationalizing its use. In fact, we should hit all the three arrows of history, investigation, and treatment in a proper sequence and then hit the antibiotics. And also let us ensure that we do not get infected with HIV virus, the human irrationality virus, out of our habit, ignorance, and vulnerability to exploitation by industry. So friends, today, let's take a pledge to be rational every day while living our life or prescribing medication by developing a rational, ethical mindset and enjoy a well-deserved REM sleep after we prescribe a course of antibiotic, which is rational. So friends, for the final slide on my take-home message, ignorance about the latest in your area of expertise is not bliss, it is missed. It is missed diagnosis, missed treatment, missed clientele, missed reputation. Shake up your CPUs to delete old file, download new guidelines which are available every few months. Scrutinize every statement in promotional CMEs. Often the speaker never highlights the shortcomings of a molecule. Hence, be wary of pharma promotion. It always backfires. Diagnosis, diagnosis, diagnosis. It should be the quest by hitting the right arrows in right sequence. Until then, we should communicate, communicate, and communicate. It pays you rich dividends in the form of respect from patient. And second, don't just imitate the prescribing norms of your senior, but analyze and improvise to hand out better prescription. And last, don't ever succumb to the demands of patients for an antibiotic. So friends, pardon me, one more time, one more slide. Coming to what concerns us as a group, are we guilty of inking antibiotics, over inking antibiotics? So most of us will say in unison, no. After all, we are brainstorming together as a big group at Cloud9 in these webinars. So let me give you a crude comparison. Across all NICUs of Chandigarh, the antibiotic usage was 22 to 90%. We are at 22%, let me make it clear. And as per a recent study from state of California, where 1.6 to 42% babies received antibiotics and number of babies treated per proven case of sepsis was 11 to 335. So did that mean that they had high load of sepsis in their unit? No, that is not true. So study finally concluded that this antibiotic usage in these institutions is a holdover from the prior era of neonatology, where many newborns receive antibiotic because of the concerns about whether sepsis could be detected quickly enough in these babies, and also if these babies give enough time to respond. I'm sure with decades of research, our perception of subtleties of disease is not so crude. We have better understanding of early signs of sepsis, both in terms and preterm babies, better lab parameters, and backing of robust research, which allows us a very, very acceptable wait and watch policy in these neonates. Now, last, an introspection about how we look at our subjects who are the most delicate, dynamic, and evolving every day. The signs of illness in them subtle, vast spectrum of microbes intriguing, most unhelpful Dracula-like labs, and a risk of rapid worsening, bugs threatening to spread all over, limited armamentarium of antimicrobial that we are left with and possibility of adverse effect, and yet we are the most rational amongst all intensivists. So says the world, you are the flag bearers of rationality. So you be the guide, save the humanity. Here comes a small gesture of, as a token of our gratitude towards your compassion to heal, and no better person to receive this on behalf of all, Dr. Kishore. Thank you so much, friends. It was wonderful giving this talk.
Thanks,
Brilliant
Dr.
talk,
Mahesh, for
Dr.
the
Mahesh.
wonderful talk. And very entertaining and a very useful message for all the doctors there. Now session is open for questions.
Mahesh, as usual, that was a brilliant presentation and a fantastic lecture. And I'm sure there'll be a lot of questions. And the only person who can give a flowery language of how good it is probably Arvind. Arvind, you want to say a few words about Mahesh because you don't know him, and you have the flowery language. So if there are no questions, I wanted to mention a couple of things. See, we did an audit of our Jayanagar prescription of antibiotics, and we found 21% of our outpatients are given antibiotics. And one of the good things is we get patients almost from Whitefield and Marathalli, which is like another city. Basically, it takes 2 hours to come to Jayanagar from there. And a lot of patients come from there purely because the word of mouth has spread saying that we don't give antibiotics unnecessarily. In fact, yesterday I had a video consultation with one of our old Cloud9 patients because they live in North Bangalore near MS Ramaya Medical College. From there to Jayanagar, it takes 2 hours. And in the first 7 years, they lived in South Bangalore, and now they live there. So it's almost last 6 years I had not seen that child, and they took a video consultation purely because they said the child has got fever, and they went to the usual pediatricians and they were given 2 antibiotics. And they told me this after the consultation. And they remember that in the last 6 years, they had 17 antibiotic courses. But in the first 6 years in Jayanagar, they had only 1 course of antibiotics. So remembering that, they called me and took the video consultation and explained the symptoms. And the child had a fever of 101 and 102, but playful, typically arguing with the father and other things. So I told them it's probably viral. Wait for 3 days, and if it doesn't settle down, let us do a blood test. They felt so happy and said, this is why we didn't start the antibiotics given by the other pediatrician. So sometimes the loyalty of the patients, why I'm telling this is increases because a lot of the patients know that antibiotics may not be required and they want to hear from the pediatrician rather than anything else. Though some people would have started them, sometimes authoritatively saying it's not required helps our course. What do you feel, Mahesh?
Certainly, in my last slide, I said communicate, communicate, communicate. Even if we are 25% sure that this infection might turn out to be a bacterial infection by having a look at the way the tonsil is conducted, still we can afford to wait in a big child, and we can communicate that if in case over next 48 hours, if the child worsens or shows some localization, we will give antibiotics. The world is divided into exactly half of 50% population pro-antibiotic, 50% anti-antibiotic. It is very difficult for us to strike a balance and to convince them that here it is required, here it is not. But then ultimately we are the pilots flying the aircraft, and we have to communicate effectively with them to understand this fact.
Good morning, Mahesh. Excellent presentation, very interesting. Just a note, coming from UK, where the healthy term newborns, though in India there's multi-drug resistance, I found that in UK, the healthy born newborns tend to get more prophylactic antibiotics because of the NICE guidelines. There mentions 2 risk factors about prolonged rupture and any risk factors of like fever in the mother. In UK, because there's more push for normal deliveries, most of the mothers come into labor only after like a day or so after rupturing membranes. So invariably, every 3 or 4 babies ended up having antibiotics, like even though the babies were. Sure. But I think at least in India, in here, Cloud9, most of the healthy newborns, because they don't have prolonged rupture in the first instance, they do well. I think we don't give the antibiotics unless they get admitted to NICU. So I think, do you find the difference?
Yeah, it is the study I mentioned, which has been done from the towns more than 1 lakh. I wish we could do some similar study in towns which were less than 1 lakh, because our national guidelines also for so many years say that if you have a child who has respiratory rate more than 60, has some recession, give antibiotics blindly, amoxicillin is used. So I think if we look at the prescriptions coming from smaller towns or the rural area, we may find higher usage of antibiotics. The same thing happened to the use of chloroquine, that it was a blind therapy being given to anybody who had non-localizing fever, and where we ended up having chloroquine resistance all over. And finally, in 2010, government stopped this empirical use of chloroquine. The same will have to be done by training Anganwadi workers a little better, and one will have to stop this usage, even though this figure of 461 prescription from India and 555 from UK, that way may be, a underestimation.
Sure, thanks.
Mahesh, excellent presentation. Sorry, earlier my microphone seemed to freeze up.
Thank you, sir.
Very well done and very interesting. I just have a question for you.
Yeah.
What does happen to the microbiome when you use antibiotics? I somehow have the feeling that antibiotics kill the good guys that the babies have, the good microbiome, and hence actually predispose for the bad fellows to proliferate. What's your thought on this, or any evidence?
No, see, whenever we take antibiotics, when they go into the gut, they are bound to kill the bad bug as well as good bug. So that I mentioned that, commensals will also be killed. That's why we have altered microbiome after the course of antibiotic, and this impaired gut flora stays there for weeks. Our attempts to give probiotic is just one attempt, but the microbiome is specific for a human being. It cannot be restored simply by a blind probiotic prescription. So definitely antibiotics do affect microbiomes, the good bacteria, the normal commensals which are present in our gut.
Any
Dr. Mahesh,
any comment as a follow-up? Any comment about altered microbiome because of antibiotics leading to obesity? Any papers on this? Because I remember reading somewhere.
I won't be able to quote such, but yes, I have come across, probiotics are being mentioned everywhere for every disease, for every ailment, and for every, side effects are also being mentioned. So specifically related to obesity, I haven't come across any study. If I will, then I'll let you know.
Dr. Mahesh, with regards to probiotics you mentioned, what's your take on some clinicians prescribe probiotics along with the antibiotics, just in case baby tummy gets upset? What's your take? Do they sometimes normally prescribe probiotics with antibiotics? So it's not a good idea.
So, coamoxiclav is the commonest antibiotic which will produce diarrhea. Even in that, 50% children will, 50% will not. So what I do is we wait for a day. If the child develops diarrhea, or if child has to develop diarrhea within 24 to 48 hours, then we may prescribe appropriate probiotic. Our probiotic choice has to be appropriate. All probiotics do not give you the desired results.
What do you mean appropriate? I mean, how do you select those?
For antibiotic-associated diarrhea, Saccharomyces boulardii is the only one. Lactobacillus rhamnosus GG has been trashed in a recent study. I mean, we've been hearing about rhamnosus GG for last 25 years. When we got the molecule, so came the study from US and Canada that it is no good.
Thank you.
So I'd like to make a few points.
Yeah.
For all our junior doctors who are in this webinar, whenever we deviate from the protocol, we have a form to fill in. And when we did the audit, which is presented in a Connect, our only it is compliance is only 40-50%. So first thing is most of the people may not be aware there is a form to fill in, especially when you reach meropenem or colistin stage, or when you deviate from the first line, you jump to second line straight away. So please start filling in the form because that has been audited. That is first thing. And second point, sometimes we come across a child even for watery diarrhea, someone has started antibiotics. And we normally stop the antibiotics straight away. So sometimes we may have to take bold steps, and it is not required. There is nothing called you should finish the course of antibiotics. If you think clinically not indicated, just stop it.
True.
That is one. And even though this multi-drug resistance, the national emergency, the topmost priority, most of the developed countries, is the terrorism. Second one is antibiotic resistance in most of the developed countries. Now corona might have taken that place. So we have to be very careful. Now we are sitting on this ticking time bomb. It is already exploded and already many people are dying in the ICU. There is no antibiotic to use actually. So these are the points.
Sure, this is perfectly acceptable. one thing very heartening, that when we use antibiotics in our NICUs, at least there is a lot of rationality, and the prescription or whatever orders we give are open to scrutiny by our fellow colleagues. So this becomes an important factor in restricting the misuse of higher end antibiotics in our NICUs. But in OPD there is no control, because as I said, there is a solo person writing antibiotics, prescriptions going all over, and there is no control. Nobody can stop him.
That is the biggest problem. Actually, according to your study, 78% is prescribed by the GP.
Yes.
And who is going to educate them and
Yes.
sensitize them? And also this veterinary doctor, left and
Yes.
right they are using.
True.
So to reduce the drug resistance, we have to tackle those two main groups.
I think the pharmacy would be able to give us data each center about the number of patients number of antibiotic uses per OPD per month.
No, we should be frank enough to commit ourselves that, okay, I have prescribed, and, when, like, for example, I tell, my colleagues that if we have given for acute follicular tonsillitis, mention it, day 3 of antibiotic, pus point, or a membrane seen on right tonsil or left tonsil, and a tender jugulo. This will be indication in brackets after the diagnosis, so that anybody who sees such a patient in follow-up will know that on day 3, I have to look at the right tonsil and look at the size of the